Okay, everyone, welcome back once again to the noon meeting of the Rotary Club of Baton Rouge. This is still our hybrid or our virtual meeting. Would love to be able to do the hybrid thing again. We're just not able to. Rotary International has put it on their website that they would prefer clubs not to be meeting right now just because of the whole pandemic thing, which we're going to hear a lot more today. Our speaker, Dr. Joseph Kanter, who is the State Health Officer for the State Department of Health, had to practice saying that. He will be giving us a whole lot of updates, and we'll have a really wonderful Q&A hopefully afterwards. We are doing the blood drive outside, so the mobile van's right outside of the office. There's still plenty of time slots available. If you want to come to the Rotary office and give blood today, please do so. The last available appointment is at 1:45 today. So come on, give us some blood. It's in serious need. So we'll start off with the invocation from Andy Bush.
Father in heaven, thank you for your love, grace, peace, and hope. May your love guide us in our intentions and interactions with others and compel us to look beyond our condition to help others. May your grace permeate throughout our lives and unite us with others. As we have experienced it, let us extend it toward our fellow man and fellow woman. May your peace resound in our hearts and become our anchor when so many voices out there may try to divide us. Let your peace be our anchor in those moments. And may your hope remain with us, and let us continue to hope in you and in your provision. Thank you. Amen.
Thank you, Andy. And now the pledge will be led by Phil Brantley.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
And Cindy Seegers will lead us in the four-way test.
Of the things we think, say, or do, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Okay, and one quick announcement. We're going to have a lot more information to come about this, but mark your calendars. April 10th, which is a Saturday, we will be involved in a trash pickup along the banks of the river and just in and around the greater Baton Rouge area. We're going to be doing this in coordination with the Mississippi River Cities and Towns Initiative and Rotary International. There's going to be 3 cities involved. This is a pilot to get this done. St. Paul, Minnesota, St. Louis, Missouri, and Baton Rouge are the 3 pilot cities. And we'll have a lot more information and we'll get this going. So now, Carol Potan, our club secretary, I think that's your title this year still, and is she's going to introduce our guest.
Good afternoon, Rotarians, and I am indeed honored to be able to introduce our guest speaker for this meeting. Dr. Joseph Kanter serves as the State Health Officer for the Louisiana Department of Health. Over the past several years, he has served as Principal Deputy to the State Health Officer and lead public health official for the Greater New Orleans area, coordinating regional clinical services, emergency preparedness, infectious disease control, and strategic health initiatives. In his former role as director of the New Orleans Department of Health, Dr. Kanter led the city's comprehensive opioid mitigation strategy, which included issuing the first in the state standing order for naloxone, equipping the New Orleans Police Department with the reversible medication, increasing availability of medication-assisted treatment, promoting harm reduction services, and initiating a citywide effort to reduce the stigma of addictive disorders. He is also a clinical assistant professor of medicine at LSU Health Sciences Center, adjunct assistant professor of medicine at Tulane University School of Medicine, and a practicing emergency physician at University Medical Center. As a practicing emergency physician, Dr. Kanter cares for a broad spectrum of extremely diverse patients in the New Orleans area, including some of the most vulnerable in our community. He is committed to academic education and works closely with residents, students, and other learners. His primary interests are expanding access to healthcare, promoting health equity, and developing innovative methods of keeping frequent users of the emergency department healthy, productive, and out of the hospital. Please join me in welcoming Dr. Joseph Kanter.
Dr. Kanter, if you can hear me, I think your mic is muted.
Yes. Can you hear me now, Haggai? Okay. Well, Zoom issue. So, Carol, thanks for that very warm welcome, and Haggai, thank you so much for inviting me to join. I do want to say this is the first time I've had the honor of joining a Rotary Club event, and the first time I have heard that four-way test recited, and I really like it. So I think I might take some of that back with me. Those are really good idioms to go about one's day by. So thank you for allowing me to take part in that. What I would like to do is to give a quick overview about where we are with the vaccine, and then talk a little bit more about what's going on with the pandemic in general, where we've been, and more importantly, what I think we have ahead for us. And I'll make sure to leave plenty of time for questions, because I know there are probably a lot of questions out there and a lot of myths that I would like to help clean up if I can. So with that, I will get started. All told, I'll tell you, the vaccine rollout is going quite well. I know it might be a little bit frustrating because everybody wants to get vaccinated and there's just not enough supply right now. But when we look at the measures of how it's actually operating, it's going quite well. And I don't know who heard the governor's announcement yesterday, but we actually passed a pretty awesome milestone yesterday. Yesterday marked the day that not only do we have about just shy of 10% of the state's population has now initiated the vaccine series, so have had at least one dose. We have now had more people start the vaccine series than we've had people diagnosed with COVID throughout the entire pandemic in Louisiana. About 450,000 people have had at least one dose right now, and to date, there's about 415,000 people diagnosed with COVID. So that's a big milestone. You know, this is a long road, and to think back a year ago, 13 months ago, we didn't even know the virus existed, and to now not only have a vaccine that, you know, in theory works, but actually is being produced and administered and distributed, and have two of them, about to have a third one, is just miraculous. I mean, it's just the most miraculous scientific achievement I think we've ever seen. It really is remarkable to have a vaccine, a very good vaccine, I should say, out this quickly. So it's not quick enough because we have a lot of people that want to get vaccinated that haven't been able to yet, but pretty quick compared to what has been possible, you know, historically. So I can tell you we've had those 450 people that have had at least one dose. About 190,000 have completed the vaccine series, had both doses. So total shots in arms now is about 640,000 people or so. An equally impressive number to me, although it might not seem that way, I think, to people that aren't deeply involved with the vaccine rollout process, is the number of providers that we have enrolled as vaccine providers. And we now have over 2,000 potential and enrolled vaccine providers across the state. Now, at any point in time, we're not able right now to supply all those people, all those providers with vaccine. And these are hospitals, clinics, pharmacies, and some other providers. For this week, for example, we're able to supply about 408 of those providers with vaccine, and that number was a little bit up and down every week or so. But we have many more providers enrolled than we have vaccine to give. It's actually quite complicated to get a vaccine provider enrolled. It has to roll up through us in the Office of Public Health, and it has to go over to the CDC. They have to be onboarded and trained and given access to the online system and all of that. It's a fairly involved process. The reason why it's important for me to share that information and why I think it's meaningful is, you take a step back and look at how every other states are doing the vaccine rollout. And one of the interesting things is how different it is across states. Every state is doing it differently. What we have done here is focused on a wide and broad vaccine strategy. Some states have taken the opposite approach, and some states have really focused on large events, mass vaccination events or big events in a stadium or an arena, so forth. And you can do that. You can put all your doses towards that. But when you do that, you lose the ability to push vaccine far in every corner. We took the other approach. We wanted to have vaccine really across the state. So, we're proud that we can put vaccine in all 64 parishes. And within those parishes, we have enough leeway that if we identify a community or group or population or locality or neighborhood that is not well served for whatever reason, and we identify these all the time, we have tools that we can use to bring them online. We can add another vaccine site in that neighborhood. We can send a strike team out. We can do other things to help address that. If you throw all of your vaccine doses, again, this is while supply is so limited, just to big events, you lose the ability to respond in that type of granular and flexible way. So it's done well for us so far. When you look at how each state ranks, and the CDC puts out new numbers on this every day, we're about in the top 25% of states in terms of how many doses we've administered as a function of how many we've been allocated. So we're using doses quickly. They're not sitting on shelves. Any given week, we use about 95% of the doses sent to Louisiana within 7 days, which is a pretty good measure. The real reason why I'm encouraged by having this broad network of 2,000 providers enrolled, ready to receive if we just had enough vaccine to give them, is down the road, and we can't get there soon enough, but down the road, supply is not going to be the problem. There's going to be more supply. And when that happens, we're going to have to fire on all cylinders. We're going to have to do it all. We're going to have the big events, and we're going to have vaccine providers small and wide, small time clinics and pharmacies, medium-sized ones, big hospitals, all of it. We feel pretty confident in our ability to run these big events. We get a lot of practice in it. We practice every year with flu vaccines. We have mass vaccination events every year in the launch of flu season, and kill two birds with one stone. We get to give out a lot of flu vaccine while practicing how to run these big events. And that's the reason we do it that way. So we actually feel confident in our ability to run these events. We felt less confident going into this in how well we can stand up this broad network of vaccine providers, some of which have never formally interacted with the Office of Public Health before. We thought that was the harder thing to do. So we tackled that first. Not a lot of states did. We tackled that first, and now we've built this broad network that once we have enough vaccine, once supply increases, we'll be able to flip this on easily. And I think other states that took the other approach are going to be a little bit flat-footed when the supply does pick up. So I really do think this strategy pays dividends for us down the road. And the reason I say all of this is because we get asked the question a lot, well, how come you're not doing an event, in the arena or something at the convention center or something like that? And the reason is, well, we could, but we would have to take vaccine from all those other places. And we're actually using vaccine pretty efficaciously right now. It's moving through the system very quick. So that is encouraging to me. We very recently went down to 65 and above for eligibility. There's still many more. That gives us about just shy of 1 million people who are eligible for vaccine, just shy of 1 million people. And we haven't been allocated 1 million doses. We've been allocated just shy of 500,000 doses. So you can see clearly how there's a mismatch between supply and demand on this. We are anxious, very anxious to get to other eligibility categories. And that would include people with underlying health conditions, of which there's a lot. There's about 1.6 million in Louisiana. If you just use the 12 conditions that the CDC says puts you at confirmed high risk of COVID complications by the data. We're anxious to get the teachers as well. We're anxious to get to people less than 65, maybe 55 and above. When we can get there is really just a factor of when supply picks up. We have a lot more ability to give vaccine out right now than we do have supply. We think supply is going to be fairly steady and flat for the next few weeks. On the horizon, though, is the Johnson & Johnson vaccine. And I'll talk a little bit about this because it's very exciting. They have applied for authorization from the FDA. The FDA has set a date of February 26th to hold the meeting. We anticipate, given the data that has been made public so far, them to get authorization. There'll be more data made public. One of the nice things the FDA is doing with these vaccines is they're a couple of days ahead of these meetings releasing all the documents that they look at. It's not something the FDA typically does, but in the effort to maintain transparency here, particularly with all the vaccine myths out there, this is the right move. So we'll get a ton more documents coming in about how the vaccine really performs and the side effects. But assuming it all is as it's being billed, then the FDA will authorize that sometime after that February 26th meeting, and we'll have the Johnson & Johnson vaccine shipped maybe end of February, beginning of March, ballpark. It is exciting for two real reasons. One, it's a much sturdier vaccine. It doesn't require this really complex cold chain that, for example, the Pfizer vaccine requires. Pfizer has to be kept ultra cold. That's negative 60 to 80 degrees Celsius. It's a real operational challenge, and it limits where we can put it. It makes it hard to take the Pfizer vaccine and use it for a community vaccination event or a mass vax event, something like that. The other really exciting thing about the Johnson & Johnson is that it's a single dose. The ones we have now are 2 doses. Single dose is easy and very easy to use it for a mass vaccination event because you don't have to worry about bringing people back 21 or 28 days later. So we couldn't be more excited about it. The preliminary data on the J&J vaccine is really good. It got a little bit confused in the headlines because some of the endpoints in the trials were different from the endpoints in the Moderna and the Pfizer trials. But for the categories that really matter, which is how well this vaccine prevents hospitalizations, how well it prevents death, the likelihood of someone who takes the vaccine from getting sick of COVID or dying of COVID are extraordinary, 95% and above. And not a single person in their trial died of COVID after they had the vaccine. So really remarkable vaccines, all 3 of them now. I'll tell you, so all 3 of the vaccines are going to hit, by those measures, 95% efficacy or above. And in terms of vaccines, that's like a grand slam. I mean, a few months ago, before we really knew what the vaccines were going to be like, we would have been thrilled with a vaccine that was like 60% efficacious. And a lot of vaccines we take commonly are. The flu vaccine, the seasonal flu vaccine, is oftentimes less than 60% efficacious, and it still makes a big difference in the community. I can only think of one other vaccine offhand, the measles vaccine, that's higher than 95%. That's 98%. I can't think of any other vaccine offhand that's good. This is an absolute home run in terms of vaccines. The challenge for us now is just to use it as well as possible, to make sure we don't waste any of it, to make sure it's used as quickly as possible. It really is a gift to have 2 and about to be 3 vaccines that are so efficacious and very safe. I'll talk a little bit more about that in a second. I do want to transition just for a moment and talk about what's happening with the pandemic now. Where are we? What's going on with it? And a few things. Number one, we clearly peaked. We had a 3rd surge around Christmas and New Year's time due to travel and gatherings, which was predictable. We clearly have peaked from there, and now we're coming down the other side of it. Percent positivity is going down statewide. It's at 6.4% right now. That's down from 8.3% the week prior. Hospitalized COVID patients across the state are at the lowest point now that they have been since Thanksgiving. We're clearly going down the other side, but there's a couple of things that give me concern and pause on that. Number one, we're going in the right direction, but we're still awfully high. The amplitude is extraordinarily high right now. And as of today, if you were to go on to our map on our website and look at the transmission risk by parish, and this is based on CDC criteria, all 64 parishes would have been in the highest risk category, dark red, in terms of your risk of transmission. Now we update the website. We update this measure, I should say, every Wednesday at noon. So it actually just got updated. If you were to go on now, it would show all but 7 parishes are in the highest category. Either way, to be frank, there's a ton of COVID still out there, a ton of it, still circulating, still causing people to get sick, and still causing a lot of mortality. About 3 or 4 days ago, we passed the 9,000 total death mark since the pandemic started. That was a grim milestone. And the first 3 weeks, January, we added a total of 1,000 deaths in 3 weeks, which is just unacceptable for us. So I think we have to work harder to drive transmission down. We can't allow so many Louisianans to continue getting sick from this, particularly when we know how to stop the spread, which really is through distancing and masking and doing exactly what you all are doing right now, which is choosing to have functions virtually where it's feasible to do so. It's not as good, it's not as nice, but it is safer, and that makes a big difference now. The other thing that's giving me pause are these variants that are circulating. And they're going to continue to circulate, and they're going to grow in numbers. So the most prevalent one right now is called the B117 variant. It's also being referred to as the UK variant because it was predominant in the UK up to a couple of weeks ago. And so I can tell you, as of last night, we had 8 confirmed cases of this variant in Louisiana and 24 cases pending confirmation with the CDC. Most of those, if not all of them, are going to end up being positive. We don't do a lot of genomic sequencing in the US. This is where you take the virus sample, and instead of just testing it, is it COVID positive, yes or no, you actually sequence the gene and find out exactly what strand and where it's been and what its qualities are. We don't do a lot of that here. Some European countries do much, much more than we do. So we're somewhat flat-footed when it comes time to have visibility on these variants and respond to them. It ends up being like a tip of the iceberg scenario where when you have 8 confirmed and 24 possible, it means you have a ton more circulating under your nose that you just don't know for sure. You just can't confirm, but we know we have that. It's the same thing. Think back about a year ago to Mardi Gras, particularly in New Orleans. Looking back, we had a ton of cases circulating in New Orleans. We just didn't have the testing capability to really know it at that time. That's what's happening now with this variant. The CDC predicts it will be the dominant strain in the US sometime during March. And they tell us that the best data to date shows that it is doubling in numbers every 10 days. What we know about it is it's more transmissible, anywhere from 30 to 50% more transmissible. It likely makes people sicker, perhaps even 30% higher risk of hospitalization. And thankfully, we still think that the 2 vaccines we have, the Pfizer and the Moderna, are a good match for it, which is encouraging news. Practically, what does it mean for us? I'm pretty sure, and again, I can't predict the future, but I am looking ahead, and I think there will likely be another surge in Louisiana's experience before we get to herd immunity. I'll tell you, it's disappointing news because I had really hoped that after this New Year's and Christmas surge, we could coast down gradually until midsummer, late summer, when there would be enough people vaccinated by that point in time to build up enough herd immunity to really abate the pandemic. That was the hope. I don't think it's possible at this point. I would love to be proved wrong, and I can't predict certainty, but looking at the variant, I think we probably have another surge at some point in the next month or two before we get to the summer. That leaves me with 2 things I'll ask of folks with that in mind. Number one is the best thing we can do now to prepare us to weather that surge, which would be a 4th surge for the state, is to drive down transmission as much as possible right now. The level at which you enter a surge is directly related to how high you get during that surge. Remember, how high you get means how many people get sick and hospitalized, how many people unfortunately die. The more we can suppress transmission now while we have numbers going in the right direction, the better off we'll be during the surge. There's just no question about that. One of the reasons we were such a rough spot during this last surge in Christmas and New Year's is because we started from a pretty high place. I want to start from a lower place now. I want to reduce transmission as much as possible. And that means doing all the things that we know work: distancing, masking, avoiding crowded indoor spaces where possible, doing anything outdoors that you can do outdoors. The other thing that's important is we got to make sure we use every last drop of the vaccine. We can't let any of the vaccine go to waste. And for people that are eligible, that are wavering if they want to get the vaccine now, if they want to wait, I would encourage them to get it now. Because every single person that gets vaccinated, that's one less person that could potentially get sick or die if and when this additional surge comes. It's just that simple, that direct. There are a lot of myths out there about these vaccines, and I'll kind of touch a couple of them, but I'll just tell you straight up, these are extraordinarily safe vaccines. Extraordinarily safe or safer than anything else that people get in terms of routine vaccinations and many medicines. You know, it's not going to feel that way in the media because with so much attention on this, any side effect anywhere in the country is going to get blown up. And, you know, but with millions and millions of people getting vaccinated, you can't let these little anecdotes sway the numbers. And by the numbers, it's an extraordinarily safe vaccine. Just to cover a couple of the myths that are out there, it has absolutely no effect on fertility, which is one concern that I've heard. It does not affect a woman's ability to become pregnant. It likely will be proven to be 100% safe in pregnancy. The data is still coming in. There's no reason to think it's not. There's just no firm data yet, but there are a lot of pregnant women getting it and doing very well. It does not change someone's DNA. That's another myth that's out there. Really are safe vaccines. I can tell you, I got mine the first chance that was available to me. I have a sister-in-law who is pregnant. I advised her to get it, and she did. My wife and I are actually expecting now, and if she becomes eligible through her work, I don't know when that will happen, but if she does, I'm going to advise her to get it as well. So I really do think these are safe vaccines, and it pains me every time I hear someone who has an opportunity to get it and kind of delays it. So I would encourage folks to seek out answers to the questions you have now. Seek out trusted sources, talk to your doc, talk to your provider. If you have someone who is up to date on this information that you respect, talk to them. Get your questions answered now so that when the opportunity comes to get vaccinated, you don't miss it. Because really, I've heard 2 stories now of people I know whose relatives or parents passed up an opportunity to get vaccinated and then got sick. I hate to see that happen. So get your questions answered now. Don't put yourself in a position where you potentially pass up an opportunity to protect yourself, protect your family. Now, Guy, I think I will stop there in the interest of time. And I see some questions rolling in, so I'll turn it over to you.
Carol, go ahead. You've got a great question.
Hi, Dr. Kanter. I'll introduce myself to you. I'm an OBGYN, and I appreciate the statement you just made because this question kind of tags onto that. So as you know, the American College of OBGYN has not put out an official statement, which of course many of our colleges are kind of the last one to put out a statement. But of course, I agree with you 100%. And we OBGYNs believe that this vaccine is completely safe, and we encourage our patients, giving them the facts, to have this vaccine. Do you think, or when do you think pregnancy will be put on the list for criteria? Do you think it will be soon, knowing that our college hasn't put out an official statement?
And by criteria, Carol, you mean prioritization?
For immunization, I'm sorry.
You know, I think once there's definitive data out there, then it will. You know, there's the nature of these trials is pregnant women typically get excluded from the initial trials. You prove it's safe and effective in the general population first, and then you go and do trials with people who are pregnant, and that's just the way these trials work. There were a number of women who were caught in those trials and got pregnant, before they actually, or the day after they got the vaccine. Small numbers, but they've done quite well. Additionally, there's a lot of pregnant women who have now gotten the vaccine outside of the trial, just in real life. And those women are getting followed by the CDC. And there's to date no signal at all that there's increased complications. So I think once there's firm data to show without any question that it's safe in pregnancy, as many vaccines are. And I think as you allude to, we prioritize pregnant women for flu vaccine. We prioritize pregnant women for a number of vaccines. Once the data is firm, I think we're going to see societies like ACOG or other professional societies formally recommending, advising pregnant women to get it, and maybe even saying at what point in pregnancy they would advise people to do it. I doubt they're going to get ahead of the data and do that ahead of time. What they are saying now is saying, they're very forcefully saying, do not exclude pregnant women from the ability to get the vaccine. They're very clear about that. The best advice, I think, for anyone who is pregnant is to sit down with your obstetrician or your midwife and have a conversation. Have a conversation about what's right. And sometimes it might be weighing your personal risk of COVID exposure with whatever your concerns are about the vaccine. And it might be different if you are a nurse or a teacher or another job that puts you on the very front lines. Your risk is high. Maybe it makes sense for you to get it. If you're working from home, you have no one else coming in and out of your house, maybe you wait. I think those are reasonable conversations that people should have with their provider on it.
So we have several more questions. One of them, Raymond Johnson wants to know, what do you say to someone who says that the vaccines were created too fast?
Raymond, well, it's a great question. It's a great question because part of me wants them to be created faster, so we have more right now. There were some things that were done that enabled this vaccine to be produced as quickly as it was, and it was not because any safety steps got skirted. There are a few decisions that were made that I think paid off. A lot of these were made by Tony Fauci's team in the NIH. Number one, there was research committed after the SARS pandemic to create a vaccine for coronaviruses. And SARS was a coronavirus as well. That research led directly to the vaccines we have now, directly to it. That's number one. Number two, these messenger RNA vaccines, of which the Pfizer and the Moderna we have right now, that technology actually has been in place for a number of years. We've used it for cancer therapeutics and other things, so it's not new technology. And the other thing, one of the big ones, is this is one of the better decisions that I think that the Fed's made on this. The Fed's monetarily incentivized these pharmaceutical companies to start producing the vaccine at scale while it was still in trials. They basically placed a bet on it because time was so much of the essence, knowing if the trials didn't go well, if it wasn't efficacious, if it wasn't safe, they would lose the money, lose a couple $100 million that they put into producing this vaccine that would get thrown away. But if the trials did end up well, which they did, they had a head start on production. That's not something a pharmaceutical company typically does on their own because it's not worth the risk. In this case, it was worth the public's risk, and that bet paid off. None of the safety steps were skipped. These trials, these phase 3 trials, were big trials. 35,000, 40,000 people in each of those 2 trials. Big time trials, very safe medicines, just done in an expeditious fashion, but not skipping safety steps.
Great. Another question. Deborah Sternberg-Roth would like to know, do you recommend people wearing 2 masks specifically for students and teachers who are trying to go back to school to wear 2 masks in person?
Yeah, thanks, Deborah. It definitely gives you better protection. There's no doubt about that. You probably get the same level of protection with a couple of cloth masks as you might with a KN95, perhaps, depending on the fit. But it definitely gives you better protection. I don't know if we're going to see the CDC formally recommend that until there's a little bit more data supporting it. But I'll tell you, the more filtration ability, and it could be 2 separate masks, or it could be a single mask made of 2 or 3 layers. But the more filtration ability, the better that mask is going to protect both you and those around you. So I think for anyone that's in a real high exposure profession, I mean, if you're out, like a teacher, if you're on the front lines, it is not a bad idea at all.
Here's a great question. Jeff Zimmerman wants to know, if you have had a confirmed case of COVID-19 and have now recovered, do you need the vaccine?
Yeah, you do. I'll tell you, you should not get it while you are acutely ill. So if you have COVID right now, if you're a 10-day infectious window, that's not the time to get the vaccine. After that, what the CDC says is you probably have some innate protection. You certainly have some amount of innate protection. We don't know exactly how much, and it probably lasts around 90 days or so. During that time, you're absolutely welcome to get the vaccine if you're eligible. It is safe to do so, but you could wait if you wanted to because you probably have some protection anyway. So if the vaccine is scarce, it wouldn't be the worst thing to wait so that somebody else could get it. But I would never advise someone to wait if they wanted it now. Once you're over that 10-day acute infection window, it's safe to get the vaccine if you've had the virus before. And if that's your opportunity to get it, I wouldn't pass it up.
Carol, you had another question as well.
I do. So Dr. Kanter, in addition to being an OBGYN, I'm also the Chief Medical Officer for one of the community health centers here in the state. And my question from that hat is, do you anticipate using more community and rural health centers to actually administer that vaccine in those very rural and isolated and vulnerable populations?
Yeah, that's a great point. Yeah, and we need to. No question about that. And community health centers, federally qualified health centers, rural health centers are a big partner, particularly in reaching marginalized communities. And that's where we have the most work to do right now, just to be completely clear. At the moment, we're supplying 59 federally qualified health centers with vaccine. There's more that want it that we wish we could be able to supply to. I think we'll add to that a little bit. Additionally, the Biden administration announced yesterday a new plan to allocate and distribute vaccine directly to these type of clinics. It's going to start slowly. I think it starts with 25 clinics this week, none of which are in Louisiana, 250 clinics next week, which we'll probably have a couple here, and then it'll grow from there. But it'll be a good program. And they did that specifically for the reason that you say. These clinics are tailored to people that have other barriers, that are marginalized, and we need to be intentional about how we get them access to vaccine.
So we have another question from Pierce Sinman. If gators are so poor in terms of protection, and why are they, why are you not discouraging people to put something over them?
Yeah, they somewhat are discouraged. One of the challenges is that the term gator means something different if you live in Louisiana as opposed to if you live in Minnesota. If you live in Minnesota, it's a very thick fleece thing, which is quite protective, actually. So at the end of the day, the way to test your mask is put it on and blow. And if you can feel your breath going through your hand, you can also do a candle test. You can light a candle, try and blow it out from the mask. If you can blow it out, you need a thicker mask.
Oh, that's a great idea. I've not heard that one before. That's very good. We have actually you've gone international, by the way. Now, this is Richard Kalungi. He's actually from Kampala. He would like to know if transmission rates in his country, Uganda, are rather low compared to the U.S. To the point one could share a room with people for a week, bathrooms only testing positive. What's the issue with when you get to the countries who aren't having as much of a problem as the U.S. is?
Well, I don't know. I really don't know. I'm not too up to speed with what's going on in Uganda. I will say it's been curious to me why countries like India, which you would think would be a setup for a ton of COVID just exploding, haven't gotten as much as they might. I'm not sure. I think some countries are really limited in their ability to test, and if you're only testing people who are symptomatic, you're missing about 50% of the cases that are out there, and missing a lot of transmission. But beyond that, I don't know. I have no idea. Yeah.
We have another question from Deborah Sternberg Roth. She would like to know, what do you hear about the progress being made in validating whether the vaccines will be safe for people under the age of 16?
Trials are ongoing. We're pretty optimistic. We actually had a conversation with Tony Fauci about this a week ago, and he's seen some initial data that hasn't been made public. He's pretty optimistic too. He thinks they'll be approved or authorized for kids sometime around the beginning of summertime, ballpark. Right now, the Pfizer vaccine, as you allude to, is authorized down to 16 years of age, and Moderna is down to 18. And that's not to say it's not safe in people younger, it's just the trials didn't include anyone younger. So now both of those companies have ongoing trials with people younger than those ages. There's no reason to think it's not going to be safe. But once the data comes out, those companies will go back to the FDA to apply to have their authorization amended. And if the data shows that it works and it's safe, then it'll be amended, and that'll be when we start vaccinating kids.
Question from Alicia Murphy. She would like to know, what are you doing to address concern in the communities of color about the safety of vaccines?
We're trying hard, but to be honest, we need a lot of help on here because we need trusted voices. And I got to be humble enough to know that I'm not the right messenger for everyone. And what we're trying to do is find voices in communities across the state who can convene conversations, help people get questions answered. Look, I mean, there's a state like Louisiana has decades and decades and decades of health inequities and earned mistrust amongst communities, and that doesn't get reversed overnight. It's really, really challenging work, and the myths that are out there are difficult. The myths about fertility, myths about whether the vaccine was rushed or not, and it's really harmful. And my fear, which I'm sure is yours too, because you asked the question, is that uptake and access to vaccine is going to be hindered in the very communities who have already borne the brunt of this pandemic, already have had the most fatality and the most hospitalizations. So I think we need, us in the health department, we need all the help that we can get here. We need to be fostering conversations in communities. We need to give people the opportunity to have their questions answered. And we need to be finding voices within the communities who can help lead these discussions that aren't me in the health department.
Carol, do you have another question?
That was it. He covered several of the things I was going to ask. Thank you, Kanter. Appreciate it.
Letting me off easy, Carol. Okay.
I'm glad you enjoy the Rotary 4-way test. We certainly have some extra applications if you would like to join our Rotary Club.
Thank you.
Great. Yeah. Thank you again for sharing some time and helping to provide some information to our members.
It was my pleasure. It really was really nice to be with you. Thanks for joining, and thanks for the work you're doing. I learned a little bit. I didn't know a whole lot about Rotary clubs before. I know a little bit now, and I read some before and talked to some people who are associated. So really impressed with what you do, and thank you for doing that.
Well, great. Thank you very much. Okay, so that's our meeting for the day. Again, we have a few more minutes left of the blood drive. If you want to get over here to the Rotary Club office, their blood is certainly needed. Next week, Chief Murphy Paul will be our speaker. He'll be here talking about policing during a pandemic. Until then, do want you to mask up, stay safe, and if you can get the vaccine, get it.